Good evening, everybody. Can someone confirm if you can hear me by show of a reaction? Thank you. Thank you, Dennis. Thank you, Joshua. We will start in a few, maybe the next 5 minutes. Just allow our colleagues to join in. Share the link out wide for those who might need reminders so that we are all in when we begin. Thank you. Welcome, everyone. Thank you for joining this session. My name is Dr. Silvanus Manyala. I am Communications Associate at the Pharmaceutical Society of Kenya, and I'm pleased to moderate the session today, titled Pharmacists at the Frontline, Detecting and Preventing Medication Errors. We have our guest speaker, Dr. Austin Ochieng, who is the Chief Pharmacist at Malibu Pharmacy Limited, and he will be delivering the session this evening. We are looking at having a very engaging discussion, and at some point we'll have an opportunity for you to interact in the Q&A session. So feel free to use the chat for inputs, or the Q&A bit for questions that need response. I'm also confirming whether Dr. Austin is in the room. If you can hear me, just unmute.
Thank you, Doc. Yes, I can hear you.
Thank you so much. So again, this is the session. We are looking at a session for about 1.5 hours. And the program flow ideally looks like this. And just to give you a bit of context for the session this evening, we are at a time where we, as healthcare workers in the front line, experience a lot of medication error issues. And we acknowledge that this remains as a significant cause of patient morbidity and mortality. And in Kenya, of course, recent incidents have highlighted the critical gaps in prescription verification, patient counseling, as well as just public understanding of the role of pharmacists in preventing and even then just detecting the errors before they happen. We believe that we are uniquely positioned as the last line of defense against medication errors, and this final point where the medicine reaches the patient gives us an opportunity to have, the opportunity to counsel, to detect, to intercept, and even prevent these errors originating from either prescribing, dispensing, or administration. So this webinar is ideally designed to, of course, reinforce our role in patient safety, provide practical tools for error prevention, and remind the profession of its collective responsibility to protect the Kenyan public. I'd like to invite our president, Madam President, if you can hear me, Dr. Werimo Mbogo, to give us an official opening remark. Yes, Doc, proceed.
Okay, thank you so much, Dr. Manyala, for a very timely and good introduction. Colleagues, as you may know, many of you, PSK strives to at least enrich the pharmacist in terms of the practice. And if you looked at one of the key things that we had discussed or that was in our statements was that this issue presents an opportunity to strengthen our systems, improve oversights, and enhance public trust in pharmaceutical care. I know this may seem a bit reactive, but also when opportunities arise, it is important to see an issue to completion. So when you are doing the concept, one of the things that we're looking at is how do we make sure that what we're calling the Hakikisha ni Pharmacist public awareness campaign is executed in the most efficient way. Number two is that when you look at the PSK, when you look at the EPIC agenda, one of the key things that we decided to do when we noticed that there are a lot of public-facing initiatives that we need to put into context and we are too technical in terms of the highlighting of those issues, we decided to sort of carve what we would like to call a harm reduction initiative. And this harm reduction name was based on the fact that, one of the biggest harm reduction initiatives we can do as pharmacists is the antimicrobial resistance awareness. So we have been doing a lot of work around that space. And everyone, if you ask the public what is antimicrobial resistance, it is such a difficult name to pronounce. So we felt that for our public-facing campaigns, we need to have names that make sense to the public. So harm reduction now became something that is part of the bigger mandate. Part of it will have AMR. There's digital safety and awareness, and just making sure that the public is able to access pharmaceuticals in a safe way. And then now medication errors in terms of internal sensitization becomes part of this initiative, because we need to sort of check our processes internally, whether you're in hospital, whether you're in the community pharmacy, in terms of how we are reducing the medication errors. If you look at the WHO statistics, medication errors or medical related errors are part of what is a risk factor within our career. But minimizing those risk factors becomes an intentional strategy to ensure that our patients are safe. So I want to thank the PSK team, the PR committee, the practice committee, for just making sure that while our sensitivity on this is high, that we actually take the time to remind ourselves and refine our processes in terms of making sure that our harm reduction initiatives are accomplished. So for us, I think we are ready to learn. And I think what I would call upon for every pharmacist is, within this whole scenario, please look into your internal processes. And this starts from the manufacturing until the medicine gets to the patient, and think about how your processes impact harm reduction to the public and to the patient. I think with that, I would want now to hand it over to Dr. Manyala so that now the webinar can start. And welcome. Thank you for joining. I can see the numbers. We are here in our numbers. So thank you. And it means that this topic was very relevant. I want to remind you that it's already on the portal, the PPB CPD portal. Please take your time to subscribe into it, so that now the issuance of the CPD points is timely. But thank you, Karibu, and Dr. Manyala, thank you, and take over from here.
Right, thank you so much, Dr. Werimo. I want to now at this point welcome Dr. Austin Ochieng. But before he even speaks, Dr. Austin is the chief pharmacist at Malibu Pharmacy Limited, where he has practiced extensively as a community pharmacist. He has overseen medication safety protocols at the pharmacy's multiple branches, and is known for his practical approach to patient-centered care. His frontal experience makes him uniquely qualified to address real-world error prevention strategies. And now this is where we do drums roll as Dr. Austin comes to speak. Thank you so much. Welcome, Dr. Austin.
Thank you so much, Dr. Manyala. So you've already introduced me, so there'll be no need for another introduction. What I'll do is to just share my screen. And I'd like to confirm whether it is visible.
Yes, very visible.
All right, thank you. So, thank you, PSK, for giving me an opportunity to address my colleagues on this specific topic. So through this discussion, I'll share what I understand by medication errors. I'll share some of the factors that could lead to medication errors. I'll highlight a few techniques that we can apply to just try prevent and detect and prevent these errors. Very lastly, I'll share real case examples that I have experienced in my practice that can probably make us think about these things in a more professional, deeper way, as well as improve our practice. So just very quickly, as an introduction, we know that we take medicines to prevent or treat diseases. And the reason why someone would want to take a medicine is because they do not want to die. They want to live longer with a better quality of life. But then these medications that they take to, and with the expectations that they'll obtain maximum benefits from it, have potential to cause harm. And some of the harm caused by these medications can be very severe. We work in an environment where the medical profession is very adored. People trust healthcare providers, and with that trust, then it means that they'll obey whatever we tell them about their conditions. So if you tell a patient to take Panadol, they'll just go and take Panadol. Rarely do we have situations where a patient tries to contradict an advice given by a healthcare professional. So with that, then it means that they are likely to underestimate the risk of harm associated with medicines. Because if I tell a patient to take 2 or 3 painkillers, they'll proceed and take 2 or 3 painkillers. And from their side, they might not see the harm, but from a professional eye, you'll be able to see that this patient is going to have some harm from this. And so there's a lot of trust that the healthcare, or rather the patients, have put on us. And so it is very important that as a professional mandate, as service to everyone that we care about, we work as much as possible to try and prevent these things that might cause them harm. So the harm is really has very bad effects on patients as well as the people who actually do the harm. So we want to look at it from the point of if I cause a patient to probably suffer side effects or suffer harmful effects from a medication error I have committed, it also affects me as a healthcare professional. You'll want to doubt your credentials. You'll want to really question yourself. And so the effect is both ways. So it's either affecting the patient and also affecting the healthcare provider as well. This is a screenshot I took from the WHO Medication Without Harm Handbook. It summarizes the introduction I wanted to make for this particular session, that patient harm due to unsafe medical care is a leading cause of death and disability worldwide, and most patient harm is avoidable. The second point is 1 in 20 patients globally experience preventable medication-related harm in medical care, and this ratio is very high. 1 in 20 is very high. Another point I'd like us to note is that almost 50% of preventable patient harm is related to medicines and therapeutic interventions. So 50%, again, a very huge ratio here. Then a quarter of preventable harm is considered severe or life-threatening. Then errors can occur at various stages of medication use process, and I'll take us through the medication use process so that we identify the areas where the medication errors can occur. Globally, most errors occur at the prescribing stage, and then also we have monitoring, and of course there are more They occur mostly in low and middle income countries. So a few definitions here. I'll start with adverse drug events. So adverse drug events is really an injury resulting from medical interventions related to drug, including both adverse drug reactions in which no error was involved, as well as complications resulting from medication errors. So there are adverse drug reactions where really no error was committed, the patient, everything was done right, and the patient just reacted. So that's adverse. Then there are circumstances where an error is committed and then it causes injury to the patient. So that one now becomes a medication error. So as indicated in the subsequent definitions, that in adverse drug reactions, of course, a response is to a drug which is noxious and unintended, a response that is noxious and unintended, and that occurs at normal doses. And so these are unpredictable adverse drug events. So it's not unpreventable adverse drug events. And then we have medication errors where point to preventable events that cause or lead to inappropriate medication use or patient harm, where the medication is in control of the healthcare professional or the patient. So just to illustrate this, to show the relationship clearly, so we have adverse drug reactions, which we've already said that you can't prevent. And then there are preventable adverse drug reactions now due to medication errors. Now, also still under medication errors, we have potential adverse drug events. They've not happened, they have potential to happen. Then still you also have trivial medication errors. So this particular section, So this particular section here is where we have medication errors falling. So whether there's injury or there's no injury, so it becomes a medication error. Then we have adverse drug reactions, which cause injury. There are inherent risk of drugs. They cannot be prevented. Then now if we combine the adverse drug reactions with the preventable adverse drug events, which cause injury, is where we get the adverse drug events. So I hope that is clear. In the care delivery process, there are a few stages that a patient goes through. So if a patient goes sick, gets sick and walks into a hospital, there are a few stages that the patient will pass through before they get their treatment. So the first stage will be recognition and assessment, where the physicians, the doctors do their work to just assess and make diagnosis out of what the patient has presented. So that's the first step. The second step will be to, of course, make the diagnosis. And then after the diagnosis is made, now we get into the next step, which initiates the medication use process. So, of course, a prescription will be made. This prescription can be transcribed or transferred to another document, depending on the circumstance or environment. And then a dispensing process has to happen. Then the medication will be administered to the patient. Either they'll take orally, or it's injected, or it's admitted through whatever route that is appropriate as per the prescription. Then the last process would really be monitoring. So we have on this side the care delivery process, which involves recognition and assessment, diagnosis, and then selecting the intervention. And then the last step is monitoring. And then on this other part, we have now where we have the medication use process that starts with prescribing, transcribing, dispensing, administering, and monitoring. So just digging into the medication use process. So on prescribing, there's the evaluation of the patient, there's establishing the need for the medicine, selecting the right medication, then determining whether there are interactions and allergies, and then you prescribe the medicine. The next step would really be to document or transcribe this order, and then it's transmitted to the pharmacy, where there's dispensing that begins the review of the prescription order, confirming that everything is okay. If there's any issue, the prescriber is contacted, the medication is prepared and given to the patient. So the next step will be the patient to take the medication. So it's either being administered to them or them taking the medication. So again, there's that part of really counseling and advising the patients on how to take their medications. Then the last step is monitoring, which I know most of us forget, where we need to really assess whether the patient is responding to the treatment or not, whether they are getting issues with their medications and anything that needs to be done about it. So out of this process, errors can occur at those various stages. Remember, I've talked about 5 stages. So at the prescribing stage is where we are likely to get the prescribing errors. And these are mistakes made by a prescriber when ordering medication during the time when they are writing a prescription or making a therapeutic decision. So they're likely to make errors here, and the errors can be in form of either wrong medication, wrong treatment, wrong dosage, wrong route, wrong choice. Basically, anything that has to deal with the medication. They can even make a mistake by writing the wrong name on the prescription. So those are prescribing errors. Sometimes this information that the prescriber is writing needs to be transmitted or recorded in another document. It could be a discharge note, it could be an admission form, it could be anything. So if there's a discrepancy between what the physician is intending to and the medication that has been recorded on this other document, then it becomes a transcribing error. And then dispensing error occurs when there's deviation from the prescriber's order made by staff in the pharmacy. You have the administration error when there's discrepancy between how the medicine is given to the patient and the directions for administration, either from the guidelines or from the doctor who was the prescriber. Then the last one is the monitoring error, where there's failure to review a prescribed regimen for appropriateness and to detect problems, or failure to use appropriate clinical or laboratory data for patient's response assessment. So again, there's that bit. Again, just to illustrate the errors. Sorry. So on ordering, where we are saying that a prescription is being written, like I mentioned before, there could be wrong dosage, a wrong drug could be chosen, there's wrong route, allergy, or drug interaction. So these are errors that can originate from us just making, or rather prescriber writing a prescription. And then transcribing, again, when transcribing this information to another document, like I mentioned, there's likely to be an error in case someone, for example, confuses diclofenac injection with diclofenac oral. So change of route, there can be wrong dosage written, wrong patient, wrong timing for the medication, or wrong drug. During dispensing, we're likely to see either wrong selection of medication dosage. Instead of, for example, choosing carvedilol 12.5, someone chose 6.25. There could be wrong route, like the case we saw in the video we had, where a medication for, or rather, a prescriber intended to have a medication for an eye condition, but then the person who dispensed chose the one for skin. Could be wrong patient, where either names are interchanged or there's mix-up of prescriptions. So instead of dispensing to the right patient, you end up dispensing to a patient who is not there. Either the names are close or there's confusion. There could be wrong timing, where you are trying to indicate on the prescription when the patient, or rather on the label, when the patient can take the medication. Instead of saying a medication is supposed to be taken at night time, you write during the day, or you omit that information altogether. Could be incorrect labeling, or failing to label, wrong route, or failing to just check whether the patient is allergic to medication, or confirming whether there are any drug-drug interactions that need to be checked. Under administration, again, wrong patient, wrong dose, wrong drug, wrong time, wrong route, and it can either be committed by the person who is administering, if it's an injection, or the patient himself, probably as a result of wrong instructions given at the point of dispensing. Again, the errors can be classified according to seriousness. There are errors that could potentially happen. The circumstances actually favor the error to happen, but then the error does not happen. So that's really the least serious. And then we have sometimes the error has occurred, but it fails to reach the patient, what we call a near miss. Or sometimes it gets to the patient, but then the patient does not consume the medication. So it's realized before the patient actually consumes the medication. So a dispensing error. Then error can also occur and then end up causing harm. And the injury or the harm out of this error can either be temporary or permanent. So again, depends on the seriousness of the, or rather the medication that has been prescribed. And then we have errors that can actually lead to death. So it's important that we be aware of these cases. All of them are important for our knowledge. All of them are important for understanding, because an error that has not reached the patient is an error that can potentially reach another patient. So it's important that we are all aware that any mistake that happens, whether detected or not, has very significant effects as far as our systems and healthcare is concerned. I'll talk about the contributing factors to medication errors. Number one, we have categories of patients who, by virtue of their age, they are just predisposed to medication errors. We'll start with the very young. The very young, you'll want to think of the process of writing a prescription for a young one. There's calculation of dosages. There's selecting the right medication. Sometimes you are not sure whether they are allergic to medications or not. So errors can happen at that. And also when errors happen and they probably given wrong medication, given their physiological system not well developed, they are likely to get more severe effects compared to people who have well-developed system. And the same case applies to older persons, because again, older people, number one, are likely to have multiple conditions. So they're likely to be in more than one or two medications. So these are age, the age where there's more medication use compared to any other age, in terms of just comorbidities and the aging diseases that come in. So again, potential drug-drug interactions, wrong medications, mix-ups, severe reactions to any error that happens. So they're likely to tolerate the adverse drug reactions less compared to the other population. The second bit is multimorbidity, where there's presence of two or more long-term health conditions. Again, more health conditions mean more medications, because all the conditions in a person have to be treated. Again, other issues with medications come in. So a person who has multiple conditions is really predisposed to medication errors. The same case applies to polypharmacy, where there's concurrent use of 5 or more medications. Again, the issues to do with medications come in, and I'll not go over them again. We have medications that are classified as high risk or high alert medications, medications that have a higher risk of causing harm in case an error occurs. This include medications with narrow therapeutic indices, medications like insulin, medications like anticoagulants, or antiarrhythmic medications, where just a small mistake causes severe harm. We have transitions of care, where a patient is moving from one point of care to another. This can be in the hospital when probably there's change of ward, or the patient is being discharged to go home. or a patient now is being served in an outpatient facility and they have to pick medications again from another pharmacy outside, or a patient fails to get medication from one pharmacy and now gets different medications from different pharmacies. Because now then that means that some information can be omitted, or there can be misunderstanding. There's likelihood of duplication of medications, like I'll discuss in my coming slide. The other factor is really the medications themselves, because there are certain things about medications that can really cause or make it easy for an error to happen. The first one is substandard and falsified medicines. Again, we understand that if a medication is substandard or falsified, then the therapeutic outcome is really lowered when these medications are used in patients. So again, if a patient is not getting the right treatment, then really it's an error. Or the other bit on how to look at it is probably the medication is likely to cause harm, or there's a problem with it, which might cause injury to the patient. And so if a medication is substandard or falsified, then there's a potential to actually cause harm. We have certain medications that look alike. Either the packaging looks alike, the tablets look alike. We have some medications that sound alike. For example, Dulomin. There's really high risk for error because someone can really can easily confuse one medication for the other. Like I mentioned, again, medications that are likely to cause harm, those with the narrow therapeutic indices, and anticoagulants, cardiovascular medications, insulins, and the rest. So again, medications themselves, just the way they are likely to cause harm. The other point is on healthcare workers. Again, the circumstances under which healthcare workers work now as pharmacists. There's likely to be physical factors that come out in terms of fatigue, burnout, distraction, interruption. So this can cause someone to commit a medication error. There could be poor information transfer in terms of one healthcare provider giving information about medication, but then it doesn't get to the other healthcare provider the way it's intended to. Sometimes it's inexperience. You just come out of school and then you have this prescription that you've never probably dispensed before, and the handwriting is not correct, or the handwriting is not okay, or you yourself is not very familiar with the medications themselves. So the inexperience can also lead to this, and that's why I think there's heavy encouragement that any new person into the profession must work under supervision. The other one is high workload, and just the attempt to try clear these workloads. So in the process of just trying to ensure that everything is done, we are likely to commit a medication error. Our healthcare systems, again, it depends on how it is structured. It could be a pharmacy, it could be a hospital. The question will be, does the hospital really have a medication reconciliation process where every patient medication is checked and confirmed against a standard list where omissions, duplications, and errors are detected? How is the distribution system? And this really talks to our supply chain. As we might know, for those in practice, especially in community pharmacies, that the supply chain is very complex. And sometimes a patient will present with a prescription with probably 5 medications and you are only able to get 3. So before you get the others, or them just trying to walk around to get the others, there can be confusion that can happen in between, and a medication error can happen. The other one is deviation from procedures, just trying to skip a process. Maybe you're trying to skip the prescription review process. You've not cancelled the patient. You've not chosen the right medications to dispense. So deviation from procedures are also a potential cause for medication errors. I already mentioned excessive workloads, which also appear under this. We have high risk factors. Just to summarize this, that heavy workload and staff burnout, staff demotivation due to low pay, lack of proper system for detecting and preventing medication errors. And then the other one that I've not really talked about is the increased online ordering and deliveries affecting proper medication counseling. Because if you are to deliver medications to to a patient, they've ordered online. Number one, you are not having the patient with you at the pharmacy. So it means that you either devise a way of actually counseling the patient about this medication, particularly if they've never used the medications before, or the medication, or the patient start taking medication with insufficient information. So again, just as pharmacists, we might need to find a way of working around that. And I think the guidelines for the online practice really emphasize that there has to be counseling either through call or written information. Addressing medication errors. So the first point is really to establish a safety culture. Number one, we need to accept that the responsibility for medication safety lies with us because we are the handlers of medication. So we need to assume this responsibility, the seriousness that it deserves. Then pharmacists need to prioritize safety over financial and operational goals. And this is important just to ensure that even as we try to drive our businesses and financial goals, the safety of the patient really should come first. The system, we need to create a system that encourages and rewards identification, communication, and resolution of safety issues that arise. We need to have a system that provides for organizational learning from incidents. We need to have a system that provides appropriate resources, structure, and accountability to maintain effective safety systems. So in our work environments, wherever we are, it's important that we map out all our processes and just ensure that we create a system that allows for detection and prevention of these errors. The second point is really to encourage reporting of the medication errors, because again, how do we come to know that a medication error can happen? And the role of reporting is really to improve patient safety by learning from failure. So if a mistake has happened, then we quickly learn. I'm sure if we looked at the case that was on social media, we pick a lot of insights from that. So you'd want to, for example, if a patient walks in with a prescription, you really want to confirm whether it's an eye medication, an eye ointment, or it's a medication for the skin. So it creates awareness in that. And just to highlight that the reporting should be done both at the institutional level and then the national PPP provided platforms to just ensure that even as we transmit this information to the board, we have already corrected the mess and ensure that such an error doesn't happen again. There's polypharmacy. Again, patients on polypharmacy, or other patients on a lot of medications require that the medications be reviewed periodically so that everything is attained and we ensure that really they're not getting any harm from these particular medications. There could be prescribing. For example, if a patient was introduced to a painkiller and they continue taking it, you'll want to ensure that they stop, especially if the pain was managed. What I've seen a lot of times is patients continue to take PPIs, the antacid medications, for long beyond the period in which they were prescribed. So those needs to be wrote down. And even just importantly, if you review a prescription and you realize that a medication is not needed, then that needs to be removed from the list that the patient is taking. The other important bit that will really help is adding an indication to a prescription, because now it gives the clinical picture under which the doctor is basing his treatment decisions on. If you get a prescription for heart failure, for example, and then you, of course, from our knowledge, you'll want to remember all the medications that can be used for heart failure and the protocols that are followed to manage heart failure. If you see another medication, like for example an antibiotic, then you'll want to question it. So why are you having an antibiotic when your diagnosis is heart failure? So the queries will lead to probably you engaging a prescriber and reaching a resolution. So it's important, and I know this happens a lot with the insurance forms where the indications are indicated, but then for cash paying clients, then it becomes tricky, particularly for community pharmacies, because now the doctors are not used to actually rating indications or diagnosis on the prescriptions. Such patients, like I mentioned, need to be prioritized for medication review. Points of care. If a patient is transiting from one point of care to another, if there's change of wards, if there's a discharge, if there's admission, then it's important that their medications be reconciled. So just by checking, so what have they come with? What have they been taking? What has been added to their medication so that any error is prevented? Again, it will be important if we are connected as healthcare providers, where the information transfer happens electronically, because that then helps minimize the transcribing errors that might happen, like I mentioned earlier. Patients and the public, there needs to be a creation of awareness. The patients need to understand the medications well, why they take them, how they should take them, when they should take them. There needs to be patient engagement just to improve service delivery, getting their feedback. Are they getting cancelled well? Are they responding to medications, to treatment well? We also need to empower patients to actually report any concerns about the medications. You can do that through providing the PPB platform contacts, or just providing the contact for the pharmacy, so that in case a patient experiences an issue, then they can easily reach out. We've had circumstances where a patient walks in with medications they bought from another pharmacy, and they'll want you to address an issue they're having. So if a contact was provided, or a platform was availed to them where they could actually reach the original pharmacy, then such issues can be resolved. Of course, there's the involvement of patient organizations, provide patients' perspective on improving medication safety, and that will be through forums that are organized. Again, just to emphasize on patients, there's 5 moments of medication safety where a patient needs to be educated on. When they're starting a medication, they need to know what medication they are taking, what it is for, why are they taking it, what are the side effects, and anything to do with the medication. So all information is provided in a language that the patients understand, so that in case of anything, they're able to detect. They need to know, they need to have information about how they take their medication. They need to know when they should take the medication, the dosage they should take, the time they should take the medication, and the side effects they are likely to experience when taking the medication. If you tell a patient on PPIs, for example, that they're likely to experience headache, then it's easier for them to actually report the headache when they experience it. It's different from when a patient is not knowing that PPIs cause headache, and so they treat it as a new symptom or a new condition that again needs treatment. So such information is important that it's provided to them. The other one is when adding a medication, they need to know what the medication is being added. The person dispensing the medication being added needs to really conduct a review to just ensure that there's no interaction, there's no harm, there's no exacerbation of the already underlying medical condition. Again, when reviewing the medication, they need to know how long they should take the medications. They need to know when the medication is no longer needed. They also need to know when to stop taking the medication, when the treatment needs to stop, and when they should not stop. So it's important. So again, 5 moments of medication safety. So when starting the medication, when taking the medications, when adding a medication, reviewing or stopping the medication. So they need to have adequate information during these 5 moments. Again, healthcare workers, we need to develop and update skills of pharmacists in safe medication practices. We need to provide clear and full information on medicines to all members of the clinical team to prevent medication errors. We need to prescribe rationally, dispense, administer, and monitor medicines carefully, ensuring that the right patient gets the right drug at the right dosage, through the right route, and at the right time. So that is important. And I like to emphasize on the right time. Understand sometimes patients wait until it is too late before they start taking their medication. Really, the decision between when a prescription is written and when the patient decides to purchase the medication so that they can take it for their condition, some patients really take too long. And it's important, especially when a patient walks in with a prescription that was written 1 or 2 weeks ago, for you to really ask why they took that long. and probably whether they still have the symptoms and whether they need another review by the doctor before you actually dispense. The healthcare providers need to report all medication errors noted and share lessons learned following any error. Again, medicines as products, we mentioned the potential areas. There needs to be implementation of robust regulatory system and processes to ensure procured medicines are safe, including just conducting bioequivalence studies, because again, that's another area where there's a lot of things happening medically. The experience shows that sometimes you would want to give a certain brand to a patient, but then they'll say that this brand does not work for me. This is what works for me. Sometimes you give another brand when the other brand is out of stock, and then they're getting more side effects. So again, the bioequivalence studies need to be enhanced. There needs to be clarity in terms of labeling, packaging, and availability of patient information. I know it's encouraged that as you dispense medication, the patient is given information through counseling and labeling, but also just the information or rather the patient information lifted inside the package needs also to be given to them so that they are able to make reference when possible. There needs to be we need to be very keen when dealing with high alert medicines and even the look-alike, sound-alike medicines. There needs to be a clear way of identification and just double-checking in case these medications are to dispense to a patient. Medications need to be stored according to manufacturer's instructions, because again, if they're stored outside the conditions recommended, there's likely to be a downgrade. And some of these degradations are difficult to detect, especially for tablets, and might cause harm. Needs to be a way of maintaining cold chain for cold chain medications. And then the storage of the high alert medications need to be stored separately to just first of all to alert and then prevent picking errors that might happen. The pharmacist professional mandate. So as we all understand, we act as the final checkpoint in the medication use process. And the key roles we'll perform there are: number one, detection and resolution of prescribing errors, conducting medication reviews and medication therapy management, patient education and counseling, monitor patient treatment and compliance, and then lead system level medication safety programs, particularly where we work. I'll just talk about briefly about prescription reviews because I think it is important, and then I'll mention something small on medication reconciliation before I go to my case studies. On prescription reviews, it can be, number one, a prospective prescription review, where you just conduct a real-time check before dispensing. That if you receive a prescription, then you just go through all the steps you need to verify about the medications before actually dispense. Then there's the clinical medication review, which can be planned, including just offering it through medication therapy management. And then you can do targeted reviews for high-risk groups, like the elderly, patients on multiple medications, and then high alert medications. So just to mention on the prescription review process, you'll want to receive and verify whether it's legal. You check the prescriber signature and the date. You'll want to also, if it's coming from a clinic, check whether the clinic is registered or not. You'll want to ensure that the patient identification is done correctly, because again, another area of where error can be committed is when you give the right medication to the wrong patient. So you can confirm identity, age, weight, allergies, pregnancy, breastfeeding, review previous records, just check whether the medications prescribed are actually correct according to the age of the patient, according to the weight of the patient in terms of dosage, whether they are allergic to it or not. If they're respecting or breastfeeding, then these are high-risk groups. So we need, again, to check whether the medications are safe in pregnancy or they're safe in breastfeeding moms. It's important to confirm the indication and appropriateness of the medications. So if you have clue of the diagnosis.
Doc, we're losing you. I think your audio is breaking. Okay, I think we have Doc having technical issues. Maybe as we wait for him to rejoin, I just want to take this opportunity to remind us that we have the event live on the PPB portal, and you're reminded to subscribe. The title is Pharmacists at the Frontline, Detecting and Preventing Medication Errors by the Pharmaceutical Society of Kenya. Yes, good evening, everyone. Again, Dr. Austin is rejoining in a few, and we should be able to proceed. Apologies for that hiccup. Again, a reminder that we have the event live on the PPB portal. Remember to subscribe. And so the 7-day window period will begin today until a week later on March 13th. During this period, you should be able to subscribe and also claim your points.
Sorry, I dropped. Dr. Manyala, please confirm whether it's now okay.
Yes, we can see your screen now and your audio is also back. Thank you.
Okay, sorry about that. I think my net dropped and I didn't realize. Yeah, so I think this is the slide I was at, and I was talking about the dose, route, frequency, and duration, that they need to be correct for the weight, age, and organ function. That also need to check drug interactions. And I mentioned that there could be drug-drug interactions, drug-disease interactions, drug-food interactions that need to be checked. And then just patient factors, whether there's any adherence barriers, whether there's issues in terms of them just able to afford their medication. Because a patient can get a prescription for or rather treatment that is needed for the next 3 months, and they're only able to afford 1 month medication. So such discussions need to be held by the patient at the point of dispensing. I'll mention something on medications reconciliation. So it's really being able to create the most accurate list of all current medications and comparing the admission, transfer, discharge orders to identify and resolve discrepancies. And the goal is really to prevent unintentional changes like omissions, duplications, dosing errors, interactions, wrong drug, or formulation. So medication reconciliation is really a mandatory process that needs to happen at the key points of care transition. So if a patient is moving from one point of care to another, then there must be a medication reconciliation process being conducted, whether it's admission, whether it's intra-hospital transfers, whether it's discharge, whether it's changing of community pharmacies. If a patient buys medication from pharmacy A, and then they need to get another one in the same prescription from pharmacy B, the best thing a pharmacy B pharmacist would want to do is to actually confirm the medication they've gotten from the other pharmacy, confirm any other medication they've gotten, and ensure that everything is okay. Otherwise, there's a risk of a patient buying the same medication they've bought from the other pharmacy, and that could lead to duplication of therapy. Just in terms of process, the first thing is really to collect the best possible medication history. It means you are collecting the prescription medications this patient is taking. You are collecting you are checking if there's any other OTC medication. You're checking whether there are supplements. You're checking whether there are any other herbal therapies this patient might be on. So those ones need to be documented and listed. And then you verify the list, just confirm the accuracy. You can check with the patient, you can check with the caregiver, you can check with the pharmacy records. The next step is to compare the medication histories against the new prescription or admission or transfer orders. So for us, it will be really to compare that against the new prescription. So if a patient probably left medications at home and then they're having a new prescription, you'll want to know which medications did they leave at home, which medications are on the new prescription, and then you just ensure that everything is aligned. See what to stop, see what to initiate them on, see what to actually remove from the list completely. If there's any issue that needs to be resolved, please ensure that it's resolved with the prescriber. We are living in an age where patients having experienced what they've experienced have a lot of doubts about medications they pick from pharmacies. So for you to ensure that trust, it means that you need to link the three parties. So the patient, the prescriber, and the pharmacist need to be communicating so that the patient is actually assured that the right thing is being done. It will be not right to probably modify a prescription or advise a patient about a medication that the patient, or rather the prescriber, is not brought into the picture. So even as we do these corrections and making interventions, it's important that we bring in the prescriber. Then you document, communicate, and counsel the patient as appropriate. I'll share the case studies that I've had experience about. So I have two categories. I'll share about the prescribing errors I've experienced. I'll also share about the dispense errors I've experienced. So under the prescribing errors, the first case was a post-stroke patient who was put on atorvastatin, 80 mg and acoxia 120 mg, among other medications. When the patient visited us, she was complaining of severe muscle pain around the arm. Her doctor insisted that she needed to take the acoxia 120 despite the cardiovascular risks. You see, a patient, this was a post-stroke patient, so there's some risk in terms of the cardiovascular system and just the cerebrovascular system as well. So we suspected that the patient could be having statin-induced muscle pain. We tried talking to the prescriber to see whether that can happen. Instead, the prescriber recommended that the patient needs to do physiotherapy. But then we also managed to talk to the patient and introduced her to coenzyme Q, which is really something an ingredient that's used to manage muscle pain due to statins, and the pain was significantly reduced in 1 week. So in this case, a few things can be picked. Number one, this patient has the treatment post-stroke is right, the patient needs to be on high-dose statin. So that atorvastatin 80 mg was given. And then this patient now develops muscle pain due to the high-dose statin. So the doctor introduces acoxia 120 mg. And I remember when talking to the doctor, he mentioned that the patient could be suffering from cervical spondylosis, and it didn't look like it. So the patient was introduced to acoxia 120, among other medications the patient was taking. So I only had issues with just these two medications, because I was wondering why a patient would be put on an NSAID despite the cardiovascular risk that was imminent. So we were able to advise the patient to just take the acoxia when need be, so to reduce the intake, but then to take the coenzyme Q plus omega consistently. And her issue was resolved within a week. The second case we had was a patient that was put on an anti-allergy, Montalage, and Symbicort inhaler, and she's continued to have persistent coughs. After visiting several physicians, she was finally referred to a gastroenterologist who diagnosed her with gastroesophageal reflux disease and was put on correct treatment. So again, cases that we get to hear at the counter, because now you keep on seeing a patient coming with a prescription for antibiotics and anti-allergies and even inhalers, but then their condition is not improving, because you'll expect an asthmatic patient put on these particular medications to actually get well immediately. But then this particular patient, it took a lot of time to actually realize that what was causing the problem was actually a reflux condition that needed to be managed at that point. The other case was a chronic refill patient who had a prescription of clopidogrel 75 mg and esomeprazole 40 mg, among other medications. Again, what we picked from this prescription was that there's an interaction between esomeprazole and clopidogrel in terms of just the enzymatic activities that would lower the potency of the clopidogrel. And so we were able to just look at the prescription, engage the prescriber, and switch the esomeprazole to the pantoprazole, which is compatible with the clopidogrel, and that was done, and the patient was happy. On dispensing errors, just to share a few, we had a case where a patient walked in and mentioned that they needed a certain brand of empagliflozin. According to the pharmacist stated that the patient had asked about empagliflozin 25 mg instead of 10 mg that was on the prescription. Again, according to the pharmacist did not, rather the patient did not share the prescription with the pharmacist. So the pharmacist acted on the words of the patient. So at the end of it all, the patient suffered a very severe abdominal pain, came back to us, went back to the doctor, and then that's when it was realized that the patient had been taking the empagliflozin 25 mg twice a day, which was really a very high dose. The challenge we had here was that the patient continued taking the medication despite developing the severe abdominal pain immediately after starting the treatment. So she assumed that it was probably part of the treatment and continued taking the medication. A few things to draw from here. Number one, if this patient was counseled about the side effects of empagliflozin in terms of just inducing acute pancreatitis, and one of the presentations is abdominal pain, then they would have stopped taking the medication immediately. Number two, the pharmacist should not have, or could not have dispensed this particular prescription without asking for the prescription and verifying the dosages this patient was taking, because now that was again an oversight on the side of the pharmacist who just acted to dispense, because the patient actually took bought medications for 6 months. So there needed to be verification. Again, looking at it for this particular case, the empagliflozin had just been introduced to this patient in addition to another medication, the vildagliptin. So again, just the combination is a potential inducer of acute pancreatitis. So again, a serious dispensing error that happened. What resulted out of this was really the patient had to be admitted, and there was a surgical intervention to just manage the pancreatic damage that had happened out of this. Second case was a colleague and this was reported by the prescriber. So a colleague dispensed loxetine 30 mg to a 16-year-old instead of the fluoxetine 20 mg that was prescribed. Because it was the second time the patient was buying the medication, the patient thought that he had a new medication, so he ended up taking both the fluoxetine and loxetine together, leading to serotonin syndrome that was diagnosed by the prescriber who was seeing this particular patient. So again, number one, sound alike names, loxetine, fluoxetine, that could have led to this. Then number two, had there been history, just to confirm what the patient has at home to reconcile, then it would have been easier to actually advise the patient. Then number three was really the lack of that final step of verifying or double checking the dispensing process, just to catch up to some of these errors. The third and the last case I have for this particular session was a patient who was diagnosed with H. pylori and was put on the vonoprazan-based dual therapy. So it was vonoprazan 20 mg twice a day, and then the amoxil 1 gram TDS for 2 weeks. If you are not aware, or if you have not been informed of the current guidelines for managing H. pylori, especially the vonoprazan-based one, then you will really doubt whether the amoxil 1 gram should be given 3 times a day or twice a day. I know what we are used to in the normal H. pylori management is that we give amoxil 1 gram twice a day amongst other medications. So the patient went, now for this particular case, the dispensing personnel actually picked the right quantity of the medication, but then at the point of labeling, instead of writing TDS, take 3 times a day, the person wrote twice a day. So the patient only came to realize when the treatment duration was almost over, and he still had a lot of amoxil caps remaining. So again, number one, really verification. Number two, having knowledge about some of these treatment protocols, about the conditions. Building a safety culture. So from the cases I've given, we can really see how high risk these issues are, and they can cause a lot of issues to us in terms of just us dispensing and the errors, the effect of the errors we cause the patients. It's important that we establish a safety culture, and that will be number one by developing standardized process on prescription reviews, dispensing, patient counseling, and monitoring. I understand, and everyone understands on how prescription needs to be reviewed, how prescription needs to be, or how dispensing needs to happen, how patient counseling needs to happen, and how monitoring needs to happen. But then it's important that in our working environments, we have this process standardized where someone can just make a quick reference or just be accustomed to a certain way of doing things, where no step is skipped and nothing is left to chance. We need to create a double check system where a dispensing process is verified by a second person, because medication is before medication. So it's before the medication is released to the patient. So that needs to again happen, because some of these errors, like I mentioned, can only be caught by a second eye. It could be a more experienced person, it could be a less experienced person, but at least there needs to be checking of these errors so that they're detected well and early enough. We need to encourage error reporting and promote a blame-free culture. When a person commits a mistake, they should not be vilified, they should not be blamed, they should not be made to suffer the psychological effect of just them committing the mistake. Because what that does to the person committing the mistake is that they'll fear reporting the next time they commit a mistake, so they're likely to hide a mistake. They're likely to conceal this Number one, it reduces the learning experience we are likely to get from these mistakes. Number two, the patient harm is not addressed and can easily result into litigation issues. It's important that all the incidences that happen be investigated to identify systemic issues that predispose the team to make errors. Again, we will say that errors are not made by the individuals. Errors are made by the systems that have been created to actually cause or rather predispose the person working to making these errors. So again, as we talk about this dispensing medication errors, you as a pharmacist where you work, it's important that you go back if an error has happened, conduct a root cause analysis, identify the issues. It could be a process issue, it could be a resource issue, it could be a staff issue, it could be anything. So it's important that those issues are unearthed and addressed appropriately. It's important that we discuss and learn from all incidences for continuous improvement, just as we have mentioned. And that is the end of my presentation. Thank you so much.
Thank you so much, Dr. Chieng. I welcome any questions. If you'd like to verbally ask, please raise your hand and then we'll give you an opportunity. Doc, there's a question on the sorry about that. There's a question on the Q&A that assuming a patient comes to the pharmacy and says they have some medicines at home, but can't recall the name, and they say dawa ya white, do you send them home to come back with them with the risk of them going somewhere else to get the medication, or just give them to make the sale?
So thank you for the question. My response would be that you wouldn't want to dispense a medication to a client when they're not clear about what they're asking for. Them presenting with colors of tablets, with shapes of tablets in the pharmacy, and then they expect you to figure it out because you studied pharmacy does not make you a hero. It's important that there's clarity on what they're asking for. So if a medication was left at home, you can just request if there's someone at home who can take a photo and send to them for you to verify. If that is not possible, then you better not dispense because you don't know what they're asking for.
All right. Thank you so much for that response. Angela, did you have a question? Angela Mule? All right. Thank you so much for your time and paying attention. Again, I've seen a question on whether the session is available on the PPB portal. Just to reiterate that, yes, it is. Feel free to just log in on the... Yeah, feel free to log in to the online service PPB portal and subscribe. The event name is Pharmacists at the Frontline, Detecting and Preventing Medication Errors by PSK. And maybe at this juncture, because I note that there are a lot of positive remarks, that the presentation was very good, very nice. And this is from multiple participants. Thank you so much for that feedback. And we acknowledge and appreciate that you have been with us until this point to benefit from this session. I'd like to maybe now...
Dr. Manyala, I've seen another question.
Oh, sure.
Let's see. Let me just see. I was seeing another question on when a medication error I think happens and it ends up harming the patient. What does the law say on compensation? Like the case we had recently, the patient was asking for 1.5 million. I'm not sure, but I think there's no law with regards to compensation. Probably what we can urge our members to do is to ensure that we take professional indemnity insurance so that when such issues arise, we are able to get covered. Because you'll imagine if such issues are reported and you are seeking to make payment, it can really have a heavy financial impact on you. So again, just the other way of just going about this in case the errors happen is by having an active professional indemnity cover. Kenyan Muridi is asking that preventing medication errors requires system changes that will require paradigm change. Problem is, who pays for it? Should we bring back dispensing fees? Again, how you decide to handle it at your facilities is really you to decide. I know dispensing fees are not illegal; they should be charged. So again, it depends on what you want to, how you want to prevent medication errors. Whether you want to digitize the whole dispensing process, whether you want to just enforce systemic processes, and yeah, so it's really you to decide. Thank you.
All right, thank you so much. Dr. Desire has also shared some resources from FIP, which is the International Pharmaceutical Federation, a global organization for pharmacists worldwide. We'll disseminate this to the members. And of course, there's request for us to share the presentation, something we should be able to do. We have your contact, but again, we'll have the recording of this session shared on the on our YouTube channel for maybe future listening. And also just want to finish off with a few reminders that our conference for PSK, the 46th edition, is coming soon in June this year, between the 24th and 26th. And the theme is Pharmacists Leading Transformation and Innovation towards the highest attainable standards of health. The rates applicable at this moment in time are the early bird rates until March the 31st. We are charging student category at 18,000 shillings, while international at 350 USD. For members, it's only at 24,000 Kenyan shillings, but for non-members, slightly higher at 34,000 Kenyan shillings. We are also excited to share that we have Lipa Mdogo Mdogo payment plan. So if you'd like to pay for your conference registration in bits, feel free to do that. But again, note that it is within the period with which you've registered. So if it's in the early bird rate, if you pay, say, the first 50% now, the remainder should come by March 31st. And also just want to, again, remind all of us that the call for abstracts is ongoing. We have deadline of April 15th. That is mid next month, and we want to encourage you to submit your abstracts under the sub-themes as shown on the screen. Important dates to note is that on 10th March, which is next week on Tuesday, we plan to have a webinar on abstract guidelines, and a month later, a webinar on research methods. So again, note this in your calendars, and we look forward to having you. And lastly, again, this is a reminder that you should subscribe and claim CPD tokens by March 13th. And if you have any challenges, do not hesitate to reach out to us via cpd@psk.or.ke. Thank you so much for your attention and for joining this webinar. We appreciate and look forward to having you in the next ones. Thank you and goodbye.